I'm now delighted to welcome Dr. Claire Andrews, who is going to talk to us about ET.
Thank you very much. And thank you, Nona. And I'm sure a lot of us would love to be in that garden in Thurles right now. So, but thank you so much for inviting us down, Nona. And it's just amazing to see such a fantastic turnout. So my name is Claire Andrews and I'm a haematology consultant from Vincent's. And I'm going to talk today about ET. And in fairness, Clodagh has done a lot of the explaining already. So a lot of this will be repeating, but I think, you know, as Clodagh said, maybe some of you are here today, it's your first time. Maybe for some of you here, you've been many times and you really know, so we're just going to provide for all. So this is just an outline of my talk. So what is, essential thrombocytosis, or ET as we call it, a little bit about what causes ET, the signs and complications of ET, how do we diagnose it, and how do we decide how to treat it, and Clodagh alluded to that in terms of prognosis, and then how do we treat. And once again, this is very much an overview. So what is ET? So Clodagh explained very well there, this is, all these MPNs are bone marrow problems, and the bone marrow is the spongy part of the bone, and we call it the factory. And with ET specifically, it's the platelets that are high, okay? So with the platelets being high, it makes the blood thick, it makes the blood sticky, and therefore you're more likely to have the blood clots as Clodagh was talking about. And I suppose that's the difference with ET and PV, is really it's the platelets that are high. And these MPNs, ET and PV, are very closely related, as is MF. There are other rarer MPNs. I don't know if any of you in the room have them, but these are really particularly rare. And just a little mention about CML. CML, or chronic myeloid leukemia, is another type of MPN, but they're quite separate. The MPNs we sort of call the classical MPNs, and CML is a little bit different. So we talked there a little bit about numbers, and you know, for me, sometimes when somebody tells me a number, I 2.5 per 100,000, I don't know, for me it sort of gets a bit confusing. So I sort of thought it'd be interesting to compare it against the bigger type of cancers: breast cancer, lung cancer, colorectal cancer and prostate cancer. And you can really see the difference in how rare these conditions are, specifically ET. It really is rare. So as Clodagh said, you probably say to your patients or your family members, I have this condition, and they will say, I don't know about it. You will go to your GP, I don't know about it. And I think that's always difficult, and why these communities are so important. So it's probably about 2,000 to 3,000 people in Ireland at the moment that are living with ET. The median age of diagnosis is 60, but 10 to 20% at the age of 40. Now that number is growing, and it's not that MPN as such is growing, but it's more that we're probably picking it up better as GPs are probably, we're letting GPs know. We as haematologists do the screening quicker. And specifically with ET, there's a 2-to-1 female to male ratio. So what causes ET? And the answer is we don't really know. So, there's a question about lifestyle factors, environmental factors. Hereditary, it's not passed down from parent to child, but there definitely is these groups of pockets of patients who have, maybe some of you in the audience, that all have the same, that all have MPNs. And this is why we're doing this mosaic study that Clodagh has talked about. We have finally started to recruit in Dublin. So Clodagh was the first one in Ireland. It took us a while to get to Vincent's and in the Mater, so we have recruited in the last few weeks, which is fantastic. What have we found? So Mosaic has been open for a long time. I think, I don't know, Nona, 2019. Okay, so we do have some very initial studies, and these are what we call pilot studies. So these are very small numbers of people. Whereas now with the Mosaic study, I think it's about 600 to 700 people have been recruited. So far, they found that patients who are that JAK mutation that Clodagh talked about are more likely to be smokers. And there is a question that patients with ET are more likely to have obesity. But once again, this is from a pilot study. So this is why we need the bigger numbers. That's why we need to recruit all these people, because the more numbers, the more answers that we're able to get. And I do think it's the one question that patients ask me all the time when I'm telling them about their new diagnosis. you know, how did it happen? What did I, and there's this question of like, did I do something, which is, you know, absolutely not the case. But what we do know, we don't know why it happens, but we do understand the biology now. You know, for years before 2005, we sort of had an idea, but it was really since the discovery of this JAK mutation and subsequent mutations that we really understand the biology of these conditions. So they are caused by these apparently spontaneous acquired, as in that you acquire throughout your life, that you're not born with them, genetic mutations. So I'm not going to go too much into this, but this is this JAK-STAT signaling pathway, and this is, as Claude was saying, is this switch, okay? So this, we all have this pathway, but unfortunately with patients with MPN, this is switched on and not switched off. So it's a really important pathway in regulating normal blood cell production in the marrow, but unfortunately for patients with MPN, the switch goes on. And as Claude said, over 90% of MPNs are accounted for this acquired mutation in these three genes, the JAK2, the CALOR, and the MIPL. And Claude put up this diagram as well. And, you know, really what you can see with PV is that the majority are JAK2. I suppose with ET, it's a little bit different. And some of you in the audience will know this yourselves if you have ET, that probably 50 to 60% of patients with ET have the JAK2 V617F mutation, and then about 25% have this CALOR mutation, and then about 5% have this MIPL mutation. And then there's about these 10 to 15% of patients who don't have these mutations. Sometimes we call these mutations the driver mutations. They drive what we see in the full blood count, okay? And although we do these mutations, they're negative, we do the bone marrow and we look at those bone marrow, and we look at the cells, we see those increased numbers of platelets, and although they don't have the mutation, we say because of the bone marrow and because how the patients are, they would have triple negative disease. And Chris, who's our colleague, will talk about myelofibrosis. So in terms of, is there a difference in the mutations in terms of the patients? So what we find with patients who have JAK2 mutation with essential thrombocytosis, they have an increased risk of thrombosis. For patients who have CALOR, and this is patients who have CALOR when we compare them to the patients who have JAK2, they tend to be younger, they tend to be men, they tend to have a higher platelet count, but a lower hemoglobin level and white cell count, and indeed they have a lower incidence of thrombotic events. So this is really what's important for you. What are the symptoms? What are the complications? So 25% of patients with ET are initially asymptomatic, and we see this, myself and Claude and Patrick, you know, patients like, I had a patient there, a young patient, and, you know, he's 30 and recently diagnosed, and he's just, but I feel so well. And then a day later, I'll meet a patient and they will have had 2 or 3 years of intractable itch, thinking they were going mad, people, you know, sending them to psychiatrists, you know, so there's such a range of symptoms that you see. This is from a landmark study here, just looking at the various symptoms here. As you can see, fatigue is a massive symptom in all patients with MPN, and it's not like the fatigue that we think of. I think it's really abdominal discomfort, obviously, from your enlarged spleen that can happen. Night sweats. So early satiety just means getting full quickly, okay? So if you have a big spleen, obviously your stomach is going to be squashed, so you're just not going to be able, you're going to get full very quickly. Bone pain is very common. And inactivity, I think that's, if you have such fatigue, it's very, very hard to be active. And it's all very well for us as doctors to say, keep yourself active. And you know, keep doing exercise, but obviously it's, you know, it can be a real struggle. Itch with ET is not, it's still very prominent, ET, not as prominent as PV, but still very much there. Weight loss, obviously, from if you have a very enlarged spleen, you know, concentration problems, and fever is probably something I would see less of, definitely. But obviously, you know, these are all the symptoms, but every patient is different. You know, every patient has their own symptoms. This is just the sort of the top, the main ones. And in ET particular, if you've been around, if you've had the diagnosis for a while, you may hear the word microvascular symptoms, okay? And these microvascular symptoms are caused by the tiny blood vessels getting partially blocked by abnormal or excessive platelets. And these symptoms are fairly common and can affect quality of life, even if they're not life-threatening. So these are, you probably know this when you come to your doctor, that they'll ask you these questions. Are you complaining of headaches, dizziness, lightheadedness, vision changes, tingling in your fingers and your toes, numbness, or transient ischemic attack, or otherwise known as a mini stroke? So this is what we call the microvascular symptoms. And this is the MPN score. So this would be the score that some of you might do when you come in to see us. And this is a really good way of seeing how your symptoms are doing, specifically when you first get diagnosed, when you start a new treatment, when you change a treatment. And it can be really good at, feeling out how you're feeling. So a little bit then about, we've talked about the symptoms, and then I'll talk a little bit about the complications. And as Clodagh was talking about, when we talk about risk with MPN, it's the risk of blood clot. So a blood clot is an excess of platelets can cause blood clots within either an artery or a vein, and this stops the blood flowing. In arteries, this causes heart attacks or strokes, and in veins, if it is a leg or an arm, it's called a deep vein thrombosis, or some of you may have heard of a DVT, and if it's in the lungs, it is called a pulmonary embolism. So the risk of clot in ET at presentation is about 10 to 19%, and the risk of general heart disease is about 10%, and the risk of a TIA is small, it's about 1%. And I think this is always trying to explain this to patients about the risk of bleeding, okay? So we're explaining to you that, platelets causes clots, and then we say to you, but also when you have high platelets, it can cause bleeding. And I think for even other doctors, to tell you the truth, it's not just patients, they can get a bit confused about this. But these increased platelets can cause excess bleedings when the numbers are very high. And this is because when platelets are very high, the platelets just don't work the way they should, and they can interfere with proteins that help clot the blood. And this is a protein called von Willebrand. So if your platelets get very high, sometimes we say to you, maybe stop your aspirin, stop your anticoagulation, and that's because of this risk of bleeding. So clotting and bleeding are unfortunately both a problem. And then a little bit about transformation. As Clodagh said, patients with ET can transform onto a more aggressive form of MPN. Now, thankfully, the numbers are very small. And as Clodagh said, you can see here with the ET, she was explaining to you about the JAK mutation, and she's explained to you that there is this percentage of how your JAK percentage can increase. So with ET, that JAK percentage is about 0 to 25%. Then as somebody with ET, a small number can progress to 50%, and that mutation rises up to about 25 to 50%. And then as it goes on, that mutation percentage increases again. And that's the general transformation. But as I said, the numbers are small. So it's 3.9% at 10 years risk of changing to myelofibrosis, and even smaller again to acute myeloid leukemia. So how do we diagnose ET? So, how do us as doctors decide what to do? So the first thing we do is we outrule other causes. So the more common thing for somebody to come along with the high platelets is not an MPN. The more common thing would be iron deficiency, infection. So platelets go up with infection, they go up with inflammation. For example, if somebody has had surgery, their platelet count can be above 1,000. And then at that stage, as you know, we check for your mutations, and we go ahead and we do a bone marrow aspirate and biopsy. Everybody's favourite. And just to sort of reiterate there, the mutational landscape of ET is that 50% of JAK2 and smaller again, CALOR and MIPL. And this is how we diagnose it. These are these numbers, and we have these classifications we use as doctors, but unfortunately, not everybody fits into a perfect category. you know. So as doctors, sometimes we might have debates about all of these things, but on the whole, this is a classification. The platelet count has to be above 450. The bone marrow has to look like it has ET in it, and it has to have that mutation. So that's how we confirm the diagnosis. But as we all know, not everybody fits into the perfect category. And the next question is then, what do we do? So now we have a diagnosis of ET. So where are we going to go next? And as Clodagh showed already, we have to think about what our goals of therapy are. And these goals of therapy are very much a discussion between the doctor and the patient, because I have a goal of therapy, but as Clodagh alluded to, you have a very different goal of therapy. That young 30-year-old that I told you about who's asymptomatic, he's thinking about, you know, survival, cure, risk of transformation. That lady who had the intractable itch, all she's thinking about is her symptoms. So these goals of therapy are very different for each patient. But, you know, on the whole, the aim is to prevent thrombosis and bleeding, extend survival, control those systemic symptoms, reduce risk of transformation, and ultimately, unfortunately, we're not there yet, but cure. So very similar to PV, the ET risk is exactly the same. And once again, it's the risk of a blood clot. It's not the risk of transformation or anything like that. And very similarly, again, for the high-risk patients, those high-risk patients are patients over the age of 60, because as you grow older, you have an increased risk of heart attack and stroke. And then if you have any ET-related thrombotic or hemorrhagic event or platelets over 1,500, and then low risk is patients under the age of 60 with no ET-related thrombotic or hemorrhagic event. Now there's loads of different classifications. There is another one that we can use sometimes, and this includes that JAK2 mutation. So as I told you already, JAK2 does increase your risk of thrombosis. So there are loads of different classifications, but I think for simplicity, I think that sort of previous one is probably the one that most people will understand. So now you've been diagnosed with ET, and you've been told that you have low risk, you don't have a clot, you're under the age of 60. So the next question patients always ask me is, what can I do? How can I, you know, and I always say, just keep yourself healthy, you know, don't smoke, keep your blood pressure under control, keep your cholesterol under control, try and exercise if you can. You know, unfortunately, exercise is the only thing that will really, you know, help with energy. And then for those low-risk ET, we would say aspirin. And then I said to you already a few slides ago about the fact that those CAL-OR ET have a lower risk of thrombosis. So there is debate about even whether they need to be on aspirin. And even with patients who don't have any of those mutations, maybe those triple negative don't have to be on aspirin either. But once again, that's something we have to, as doctors, you know, do they have, are you a smoker? Do you have high blood pressure? So even if you are CAL-OR, we might still put you on the aspirin because you have other risk factors. And the other thing is if you are symptomatic, okay, so you're low risk ET, but you're symptomatic. I've got this itch, I'm getting these headaches. So for those microvascular symptoms I talked about already, sometimes it can be just as easy as just doubling the dose of aspirin, okay? And sometimes that really, really works. But then patients come back to you again and say, I'm really struggling. So sometimes though, we're giving them treatment in order to treat the symptoms by giving these, what we call a cytoreductive therapy. And cytoreductive therapy, cyto means cell, so it literally just means reduced cell treatment, but we like to put fancy names on everything. But once again, all of this is really about discussions with your doctors. You have to tell your doctor about symptoms because, you know, we're obviously in busy clinics and we're trying to do our best, but you really have to say, look, I'm really struggling. I need, you know, I really think that I could do with something, a change or... and this is just really to show, I think Clodagh showed that as well, this is the American guidance and it's all very similar. For low risk aspirin, intermediate risk aspirin, and then we're going to go a little bit into the high risk. So high risk ET, so once again, patients over the age of 60 and patients who've already had a blood clot, okay? So same thing again, we're doing the same thing. We're managing all those risk factors. We're making sure people aren't smoking. We're keeping an eye on their blood pressure, keeping an eye on their cholesterol. These patients will be on aspirin. Now, if you have had a blood clot, you will be on a blood thinner. And if you have a blood clot with an MPN, you will probably stay on that blood thinner the whole time. And I suppose sometimes, very rarely, you can be on that blood thinner and the aspirin as well. So once again, that's a conversation that we have with yourselves. And then for patients with high-risk ET, we know that if we reduce down those cells, we give you cytoreductive therapy, and that helps. So what are the options in ET? So as Claude already alluded to, first line for the younger patient is interferon. We've all had headaches with interferon over the last few years. Thankfully, at the moment, I think it's okay. The reason that we use interferon for younger patients is that initially Hydrea and interferon, the results are exactly the same, but we know after a certain period of time there is better outcomes with patients who are interferon, but it takes about 2 or 3 years. And what we're looking at specifically is that JAK percentage again, as Claude has said, that we know that after time that percentage goes down. So, will it get to a stage that in a couple of years' time that we'll be offering patients who've been on interferon a long time to come off their medication because their percentage is down so low? So that's one of the main reasons we give it to young patients. But also it's difficult to take sometimes. You have these flu-like symptoms, so the tolerability is always an issue. And then first line for all other patients would be Hydrea. Hydrea, for the vast majority of people, they can really tolerate it quite well. We just have to be careful with non-melanomatous skin cancers, factor 50 and ulcers. But for the majority of patients, Hydrea is really, really well tolerated. What happens if you're intolerant to interferon and Hydrea? What happens next? So Claude talked a little bit there about busulfan, and I also use busulfan for the older patient, and I just think it works really, really well. You give a patient maybe a 2-week course of busulfan and it can bring it down, but unfortunately it is only an option for the older patient. Some of you may be on an agrolide. It is not a drug I would necessarily always put patients on. There are a lot of toxicities in, but I think sometimes when you have little options, sometimes patients are rarely on an agrolide. So people ask me then about Jakavi. So we saw there with the PV that Jakavi or ruxolitinib works really well. Unfortunately, with ET, we know that ruxolitinib doesn't have the same results, unfortunately, than it did with PV. But it can help with those microvascular symptoms. So sometimes I put patients on Rux who have ET, and it's mainly just for symptom control. It's not very good at count control, but it can control those symptoms. So that would be the main reason that we would put patients on Rux. So, this is, and Claude put this up as well, as Claude said, we are getting good at preventing thrombosis and bleeding, and because of that ability to prevent that, we're extending survival. We're getting okay at systemic symptoms, but that reduction of, we're still not able to reduce the risk of transformation, and we're still not at cure, but certainly it's something that we're working on every day. So just a little bit about newer agents that are coming through. There is a drug called a BET inhibitor, and it can be used for specifically patients who are high risk ET, who are intolerant to Hydrea. There is some data that this drug may be good in that area, and that is certainly an area that has an unmet clinical need. When you're intolerant to those medications, we do have a gap that we need new therapy. And similarly, there's a Calor antibody that is being trialled over in the UK. Unfortunately, there's no current ET trials in Ireland, but yes, yeah, Yeah, of course, yeah, but no drug trials. But you know, we're always working on trying to open these. It's just a little bit on a sort of an up note, I suppose, with ET, that overall survival is generally very good. Many people live normal or near normal lifespans, as Nona can attest to, especially with proper management, and I think that's the key. Median survival is 20 years plus after diagnosis, but if you realise that most people get diagnosed at 60, you know, that's where you're looking at. So if you're younger diagnosis, don't think, well, that's 20. This is the average when patients are diagnosed. Many patients with ET never progress to more serious conditions, and with low-risk patients, the younger than 60, no history of clotting or bleeding, survival can be very close to that of the general population. So really, by conclusion, ET is a disorder as caused by a yet unexplained acquired genetic mutation. Symptoms and complications are very varied. A leading cause of morbidity and mortality is thrombotic complications, but this thrombotic risk is modifiable. But once the thrombotic risk is managed, survival is excellent, and the risk of transformation is low and not modifiable with current treatment strategies. So I think I am done. Okay.